respected senior professionals and dear friends, dengue fever. So in the next few minutes, I would like to talk on introduction of the dengue fever, epidemiological scenarios, etiopathogenesis, pathophysiology, clinical picture, evaluation and diagnostic markers, management of the different dengue fevers, a simple dengue fever or hemorrhagic fever or septic shock. Finally, a few words on the prevention and the control and vaccines. So Asia represents 70% of the global burden of the disease, and among the Asia, India has the largest number of the dengue cases. So the most number one capital for the dengue diseases in the world is India, with about 33 million symptomatic and another 100 million asymptomatic infections occurring every year. Half of the world's population now is at the risk of getting the dengue fever. Imagine the number of the people in the world at risk of getting the dengue fever. So the dengue fevers are considered to be an important, not only from the medical point of view, also from the public health perspective. So in the next few minutes, we would like to talk much about dengue and its consequences. First recorded epidemic of the clinically dengue-like illness occurred in Madras way back in 1780. And before that, dengue-like virus was isolated for the first time in India in 1945. First evidence of the occurrence was occurred from the Vellore in 56, and dengue hemorrhagic fever outbreak, Calcutta 63, and later, and a lot of the outbreaks have occurred in India, and all the 5 types of the 5 serotypes are available in India, and the type 2 serotype is the most dangerous one. Now, in spite of the heavy advancements in our medical field, still the mortality rates are about 10 to 20%, and if it is a dengue septic shock, it is about the 60% of the mortality rate depending on the centers. There is an increased incidence 30-fold in the last 50 years because of the climatic change, improper water storage, increase in the air travel, uncontrolled population growth, and the rapid and the unplanned urbanization. So these are all the increased proliferation of the vector, that is our Aedes aegypti, and increased virus transmission. So these are the causes for the increased trend of the dengue cases in India for the last 5 decades. So this is the main villain, the Aedes aegypti, and the most dangerous weapon is the ball-like dengue virus. So it's a mosquito-borne tropical disease, most common in the world. It's an RNA virus, a single standard from the Flaviviridae family, genus Flavivirus. Aedes aegypti, Aedes albopictus, Aedes polynesians. So these are the vectors, principal vectors available for the causation of the dengue fever in both the tropical as well as subtropical species. They are uncommon above the 1000 meters, may spend their lifetime in and around the houses. Their most important and most lovable places is in and around the houses. So you have the 3 proteins. They are the structural proteins. One is the envelope protein, and then the membrane protein, and inside is the capsid protein. And inside you can see the single stranded RNA. This contains the 7 non-structural proteins, and one of it is the NS1. So NS1 is easily detectable in your dengue rapid test, and one NS1 positivity means an acute dengue infections. As I told you, there are about the 5 serotypes. The 5th one is also detected from Malaysia and Singapore, and out of them, the most dangerous one is the 2nd serotype, dengue 2 serotype. And here only the female mosquitoes feed on the blood. The males are very good. They don't feed on the blood. The female feed because they need the protein found in the blood to produce the eggs. The male mosquitoes feed only on the plant nectar. Female Aedes mosquito can lay about the 300 eggs during her lifespan of about 2 to 3 weeks. So her lifespan is about 2 to 3 weeks. They lay nearly the 300 eggs, and each egg can stay in the environment for about a 1 year period. So the longest period egg life is about the 1 year in the water content. So this is the life cycle. If you see the Aedes aegypti mosquito, they lay the eggs, nearly the 300 eggs, and the eggs will become the larvae in about the 2 to 3 days. In another 4 to 5 days, the larvae will become the pupae, and the pupae will become the Aedes aegypti adult one in about the 1 to 2 days. So this life cycle is about the 7 to 14 days. So both the eggs, larvae, and pupae, they develop in the stagnant water. The dengue is a very complex disease. There's a lot of interactions between the virus, your dengue virus, single stranded RNA. You have the 3 structural proteins, 7 non-structural proteins, etc. And the host, from the pediatric to the geriatric population, anyone can be infected. And the vector is the Aedes aegypti, the mosquito-borne virus, etc. So this transmission is both endemic and epidemic, and finally the pandemic in many countries. See, the virus is transmitted to the human through the bite of a mosquito, and then it replicates in the target organs. It infects the WBC. So earliest finding is the leukopenia, and then the lymphatic tissues. Then the virus releases and circulates in the blood. And when the mosquito bites, the second mosquito bites, then gets the blood filled with this virus. And this virus replicates in the mosquito midgut and then enters into the salivary glands. And from the salivary glands, once this mosquito bites to a human being, then that enters into the human cycle. So this is the life cycle of the dengue virus. And if you see the pathophysiology, you have the 2 sides of the coin. And one side, you will have the production of the antibodies and the presence of the enhancing of the antibodies. And there will be the antigen antibody reaction with the complement activation. And these, they deposit on the vessels and the various tissues and the platelets. And finally, the clinical manifestation of the coagulopathy, that is the bleeding, will start. On the other hand, they activate the T cells, the production of the various chemical mediators, and they cause the increased vascular permeability, plasma leakage, and there will be the reduction of your, increase of your hematocrit, and then there will be the reduction of your hematocrit after your treatment, and finally, there will be the vasculopathy or capillary leakage. So one hand you have the bleeding, on the other hand you have the vasculopathy. These two will lead to the hypotension and the shock, pleural effusion, ascites, pericardial effusion. So there is all serogitis, and the bleeding manifestations, maybe the mucosal bleed, or maybe the bleed in the internal bleed, or the melena, or hematochezia, or hematemesis, etc. And then the finally organ involvement, maybe the cerebral involvement, or the liver involvement, or acute kidney injury, and also the lung involvement. So this is the pathophysiology of the dengue fever. So left untreated, not properly recognized the exact situation when the patient is in the DHS or the DSSS, and finally we may see the mortality also in this population. So as I told you that they have the vasculopathy, they have the thrombopathy with impaired platelet function, and the moderate to the severe thrombocytopenia. So most of the times the platelet counts will be less than 30,000, maybe 5,000, 10,000, etc. This is due to the interaction of the virus with the platelets through the IgM antiplatelet antibodies. They destroy the platelets. They also cause the bone marrow depression, coagulopathy with activation of the coagulation and the fibrinolysis, and the DIC at a later stage. As I told you that bone marrow depression, there will be the reduced megakaryocyte production. So finally, there will be the suppressed megakaryopoiesis and increased platelet clearance. So that leads to the apoptosis and antiplatelet antibodies. Here the incubation period is about 4 to 10 days, usually 4 to 7 days. The people will get the fever, etc. And you have the 3 phases: febrile, critical, and the recovery phase. So these 3 phases are very, very important. If you see a case in the febrile phase, and next the people will enter into the critical phase, some individuals they enter into the recovery phase and bypassing the critical phase. They are the lucky people. Febrile phase and then the recovery phase. But some people from the febrile phase, they will lead to the critical phase, which is very dangerous one, that may lead to the mortality, or some people they may go to the recovery phase. So in the next few minutes, I will talk you something about the febrile, critical, and recovery phase in a stepwise manner. See, this is the febrile phase. See, the illness is in the first 4 days or the 3 days. Usually the temperature will be very high, acute onset of the fever. And if you see the potential clinical issues, the people will have the dehydration at this juncture. And there will be the laboratory changes, very minimal laboratory changes. Sometimes maybe the reduction in your white cell count, that is your leukopenia. There not much change in your platelet counts at this juncture. And if you see the serology, the PCR will be the positive, but you don't find any antibodies like your IgG or the IgM. Maybe NS1 may be the positive. So that is the most earliest phase, that is the febrile phase. Here the fever will be there. There may be some element of the dehydration, not of much laboratory changes except your reduction in your WBC or maybe a slight reduction in your platelets. And your NS1 positivity will be there here. And if you see the PCR, that may be the positive. So this usually lasts for about 2 to 7 days. Monitoring the warning signs, recognize the progression of the critical phase. That is the beauty of your clinicians. So whenever you see a case in the febrile phase, see whether this patient is going into the critical phase or going into the recovery phase. So there will be the mild hemorrhagic manifestations like petechiae or mucosal bleed. And the earliest abnormality here is the total WBC count reduction. That is the leukopenia. Maybe the WBC may be 3,800, 3,500, maybe 2,000, etc. What are the signs and symptoms at this juncture? Lot of the viral fever like picture, like headache, maybe myalgia, maybe arthralgia, some retroorbital pain, anorexia, nausea, vomiting, diarrhea, flushed skin, rash. These are all almost always present in any viral fevers. So the difference here in the dengue fever and other viral fevers is lot of the body pains, bony pains, and especially the retroorbital pain. So these are the characteristic of the dengue fevers in the early stages. And if you see the laboratory, as I told you, that maybe the leukopenia with or without thrombocytopenia. Don't expect the thrombocytopenia in the first 3 to 4 days of the dengue fever. Tourniquet test will be the positive in some cases. NS1 will be positive. And some people may have the IgM antibody is also positive in the first 3 days. That is optional. Here the most important complication is the dehydration. So rehydration is the treatment here. Paracetamol is the treatment here. Bed rest is the treatment here. Nothing else. Bed rest, paracetamol, rehydration. Maybe the oral fluids or sometimes maybe the IV fluids, provided the patient is having a lot of nausea and vomiting. If the patient is not having the nausea and vomiting, oral fluids are better than the IV fluids at this juncture. See the blanchings, febrile rash of the dengue, which blanches upon the pressure. This is the earliest one. And the latter, white islands in the sea of the red. So these are such of the rashes we often see in the dengue fevers. And the next important thing is the critical period. So here your knowledge should act into the practicality. Here the temperature is afebrile. The most important point here, once the patient is afebrile, they don't stay in the hospital. So they always say that when the temperature is 101, 102, 103, they stay in the hospital. Once the temperature comes to the normal, so they want the discharge. But the actual problem starts in the afebrile period of your dengue fever. So afebrile period may be on the 4th day, 5th day, 6th day, or the 7th day. Here if you see the organ impairment, here the patient may be the shock. So you have to see the patient, you have to touch the patient. So what parts you have to see? See the peripheries, whether they are the calm or moist. If you see the pulse, whether it's the rapid pulse or feeble pulse or low volume pulse, and see the respirations, whether the tachypnea there or not, and see the tachycardia is there or not, and then check the blood pressure yourself, whether the systolic blood pressure is 80 or the 90 or the 100 or less than that, and see the diastolic, maybe 60 or 70. See the very short pulse pressure, narrow pulse pressure, mild pulse pressure. So these are all the very, very important points in these critical period, whether the patient is the shock or the not. Because shock can be divided into 2 types. One is compensated shock and decompensated shock. In compensated shock, very much treated by you with your IV fluid therapy. In the decompensated shock, definitely have to send it for a ICU setup. And here you have a beautiful laboratory changes here. So earlier, there will be the leukopenia, Now the WBC maybe fall maybe much further, maybe 500, maybe 1000, and now the platelet counts is also coming down, maybe 30,000, 40,000, 50,000, etc. And most important thing is the hematocrit. What you mean by the hematocrit? That is your PCV, that is your HCT. So there will be the plasma leakage. So because of the plasma leakage, there will be elevation of your cells. So that is your HCT or the PCV. So the PCV will be elevated when the patient is in the critical period. Once you rehydrate the patient, again the plasma will gain up, and definitely again the hematocrit level will come down. So the most important two things here in the critical period is your HCT or your PCV will go up and your platelet count will come down. And if you see the serology, as I told you that NS1 will be positive, that also will be the positive even in the critical period also. And then your IgM and IgG bodies will start appearing, and most important is IgM antibodies. So this is the picture in the critical period. So in the critical period, the most important thing is the patient is afebrile. So even though the patient is afebrile, see the symptoms or the signs of the shock and the bleeding, and then the PCB, and also the platelet counts, and then your NS1 positivity and IgM antibodies, and some people will also have the IgG antibodies provided if it is a secondary infection. So this is the critical piece. About 3 to 7 days of the illness, when the temperature drops to normal, remains below this level, so the patient will be the afebrile, morning afebrile, afternoon afebrile, night afebrile, but midnight the patient will go into the shock. So patient can either improve or deteriorate because of the critical phase. So after the febrile phase, the patient may go into the critical phase or the recovery phase. Here improve, dengue without the warning signs, deteriorate with the warning signs and the severe dengue. What are the warning signs at the juncture of the critical phase? Abdominal pain and the tenderness. If the fellow is complaining of the tender abdominal pain, severe abdominal pain, and if the abdomen is tender, so it is a warning sign for you to watch this patient. And there is a persistent vomitings, there is a mucosal bleed, the signs of the fluid accumulation, and lethargy, restlessness, hepatomegaly, splenomegaly, and finally increase in the HCT, that is your PCV, and also decrease in your platelet counts. Here what are the complications? The shock, bleed, and organ impairment. Maybe the cerebral impairment, maybe the kidney impairment, maybe the liver impairment, maybe having the jaundice, maybe elevating the urea creatinine, reduction in your urine output, the patient is not conscious or irritable, etc. So these are very important in the critical phase. So this is a shock, stable circulation, compensated hypotensive. See the hypotensive shock, capillary refill time, prolonged more than the 2 seconds, or very prolonged at mottled skin. Extremities, see the cold and clammy extremities. And peripheral pulse volume, weak and thready, feeble or absent. Heart rate, tachycardia. Blood pressure, not recordable, or narrowed pulse pressure. And respiratory rate, tachypnea, acidosis, Kussmaul's respiration. And get the ABG done here. The pH will be less than 7.4 and more bicarbonate, etc., etc. So this is the stages of the shock: initial, compensated, decompensated, and refractory shock, and finally the death. So the most important thing in the management of the dengue when the fellow is in the critical phase, identification of the shock. So luckily some people will enter into the recovery phase. We are all happy because he is recovering, 100% guaranteed to ship to his house. So here in the recovery phase, the patient is afebrile. And if you see the potential clinical issues, reabsorption of the fluid, so there will be the overload. Once in the plasma leakage, all the fluid will be in the ascites, pleural effusion, etc., etc. In the recovery phase, no fluid leakage, no plasma leakage, and there will be a lot of the fluid inside the body. So there will be the fluid overload will be there in the recovery phase. And the platelets start improving. So from 30,000, 40,000, 50,000, you will have 70,000, 80,000, 1 lakh, some people maybe 2 lakhs, 3 lakhs also. And the antibodies, NS1 will be absent in the recovery phase, and then the IgG start coming, and IgM will start in continuing in the recovery phase also. And finally, the patient is in the recovery. So in the next 2 to 3 days, the gradual reabsorption of the extravascular fluid from the intravascular to the extravascular, improvement of the well-being, a stable hemodynamics, and there will be the diuresis at the juncture. So islets of the white in the sea of the red. I have shown you the picture on the skin picture. So that is a good sign. Your PCV or hematocrit stabilizes and lowered. In the critical phase, it will be elevated because of the plasma leakage. Now the hematocrit level will be coming down to the normal due to the dilution effect of the reabsorbed fluids. And WBC rises soon after the defervescence, then the platelet count also normalizes. And finally, in this phase, recovery phase, the most important complication is hypervolemia. So stop giving IV fluids in the recovery phase. That is the most important point for our clinical point of the view. Keep on giving the IV fluids every day, 3, 4, or 5 or 6 bottles a day, even in the recovery phase. So definitely you are producing the hypervolemia. Sometimes you may lose the patient because of the pulmonary edema, maybe because of the pulmonary congestion and etc. So here, the most common cause of the death in the recovery phase is our negligence in identifying the patient is in the hypervolemia. So don't give any IV fluids at this juncture. So all these things in a single slide, your febrile period, your critical period, and the recovery. See the temperature. So more in the febrile, not there in the critical and the recovery phase. And there is a dehydration initially, later there is a overhydration. And in the critical period, you have the shock and the bleeding. And the capillary permeability, that is will be very high. And organ impairment will be high in the critical period, like your AKA, etc. And the WBC, in the early stages, it is coming down. In the recovery phase, going up. Platelets, in the early phase, is normal and then reducing, and in the recovery phase, going up. And the hematocrit, normal recovery phase, febrile phase, normal. In the critical period, elevated, and in the recovery phase, that will be reduced. And the viremia, NS1 will be positive in the febrile period, NS1 will be positive, IgM will be positive in the critical period, and the recovery phase, NS1 will be absent, and the IgM and IgG will be positive. So in a single slide, you can see all the 3 phases of the febrile, critical, and the recovery, and its important features like temperature, oral intake, urine output, etc. See, the dengue is a multi-system disease. So most of the people will have headache, fever, bleeding gums, maybe epistaxis, maybe conjunctiva. See the conjunctiva. By seeing the conjunctiva also you can diagnose the dengue fever. So subconjunctival hemorrhages are very common. And the people will have the leukopenia, thrombocytopenia, neutropenia, etc. And rash, bruising, petechiae, purpura, as far the dermatological lesions are concerned. Joint pains, arthralgia. Another name for the dengue fever is breakbone fever. So almost the people will have the very, very, very severe bony pains. So that is the reason it is also called as the breakbone fever. Altered hematopoiesis, and then there will be hypovolemia, hepatic injury. So some people will have the acute hepatitis, and then the gallbladder. Very common ultrasound finding in the dengue fever is cholangitis, or elevated bladder wall or gallbladder wall is elevated, thickened, etc. And there will be the vomiting, intestinal bleeding, and then infrequent complications. Though they are infrequent, one should remember these infrequent complications, because you have to identify these complications to avoid the death. Maybe some people may have the encephalitis, acute pancreatitis, acute kidney injury, myocarditis. That is also common. Some people know after the viral fever, suddenly they collapse because of the myocarditis. The heart rate will be 150, 200, 300, etc. So they will, if you see the echo, then the ejection fraction may be 20, 30, 80, etc. And the splenic rupture and pulmonary hemorrhages. So these are the infrequent complications, but they are complications worth noting because left untreated, so definitely mortality will be 100%. So in the clinical evaluation of the dengue fever, you have to check the blood pressure, evidence of bleeding in the skin or the other sides, mucosal bleed, subconjunctival bleed, internal bleed, etc. Hydration status, see the pulse, see the BP, see the pulse volume, etc. And also evidence of the increased vascular permeability, pleural effusion, ascites. Very common findings you see in the ultrasound abdomen in the dengue fever. Ascites, thickening of the gallbladder wall, and there is the mild pleural effusion, more on the right side, less on the left side, etc. So tourniquet test. So these are the clinical evaluation of the dengue fever. So this is the tourniquet test, increases the probability of the dengue hemorrhagic manifestations. So inflate the cuff, to a point midway between the systolic and the diastolic. First, check the blood pressure. Suppose the systolic is 100, diastolic is the 70, so midway is the 85. So inflate the cuff and wait for the 2 minutes at this juncture and count the petechial below the antecubital fossa. 10 or more petechiae the square rash, that is the positive test for tourniquet. So that's how it appears here. So 20 or more petechiae for 1 inch. And then if you classify the dengue, you will have the 3 types of the dengues. One is the without the warning signs, with the warning signs, and the severe dengue. Already told you some warning signs now so far. So you can, if the patient is not having the warning signs, that is the most dengue fever. So recovery is the rule. With the warning signs, so the patient may go into the critical phase, may get the complications, and the mortality will be very high. And the severe dengue in the septic shock syndrome. So definitely one should be very careful in treating these cases. So dengue with or without the warning signs, the lives in or travel to the dengue endemic areas with the fever lasting in 2 to 7 days, as the incubation period is about 4 to 7 days. Any one of the following, maybe abdominal pain, persistent vomiting, fluid accumulation, mucosal bleed, etc. So these are all the with and without the warning signs. What about the severe dengue? So we are very much interested here because to keep the patient with you or to send it for the ICU. So in the severe dengue, the people will have the severe plasma leakage leading to the shock. I told you 3 types of shock. So decompensated, compensated, and then extreme shock. And there will be the fluid accumulation with the respiratory distress. So you will have the metabolic acidosis and severe organ impairment. Your SGPT, SGOT elevation will be very high. And the CNS involvement, the people will have the impaired consciousness, seizures, etc. And the myocarditis is a very important complication as far as the heart is concerned. And the some people may have the acute kidney injury with oliguria and no urine output. And then elevated urea much more than your creatinine levels. And they may need a bedside dialysis to protect the kidneys. So this is the severe dengue. So organ impairment is very, very common in the severe dengue. So we are happy if you see the dengue fever with 2 or more of the following like headache, retroviral pain, etc. And you will have some reduction in your WBC or maybe some reduction in your platelets, and the recovery is the rule at the juncture. But once the patient gets the dengue hemorrhagic fever, above criteria plus the tourniquet test will be the positive. So there will be much reduction of your platelets and hematocrit rise will be 20% or the more. You should be very careful at this juncture because the patient is going into the critical phase. In the dengue hemorrhagic fever, 2nd grade, there will be the thrombocytopenia, count will be less than 1 lakh, and hematocrit rise will be there, and the people will have a lot of the bleeding tendencies, like your melena, maybe epistaxis, bleeding from the gums, and abdominal pain, abdominal distension. There will be the hepatomegaly, splenomegaly, etc. In the dengue hemorrhagic fever, stage 3, you will have the reduction of your thrombocytes, platelets, and also there will be the elevation of your hematocrits, and then there will be the shock symptoms like weak pulse rate, there will be the rapid pulse rate, etc. And finally, the shock with undetectable blood pressure, no blood pressure, etc. And definitely, these people should be admitted in the ICUs. At least DHF 3 and the 4 should be admitted to the ICUs. So hemostatic changes in the dengue hemorrhagic fever and the dengue septic shock, capillary leak syndrome. What you mean by the capillary leak syndrome? A dengue virus infected the monocytes and endothelial cells. They produce the multiple cytokines, including the tumor necrosis factor alpha. They cause increased vascular permeability. There will be the malfunction of the vascular endothelial cells and the plasma leakage will be there. And there will be the decreased plasma volume, finally leads to the DHF and the DSS. Here the fluids you have to give. Rehydration is the therapy at this juncture. And one should have a very close monitoring of your urine output, your pulse rate, your blood pressure in introducing the IV fluid therapy. Otherwise, there will be the overhydration and we may lose the patient with acute pulmonary edema. So this is a very important slide, shows you dengue viral infection, symptomatic and asymptomatic. Most of the people are asymptomatic without knowing that they are having the dengue fever. So the people will recover totally. But we are much important about the symptomatic individuals. This symptomatic individuals divide into 3 groups: mild, moderate, and the severe. What you mean by the mild? There will be the undifferentiated dengue fever, fever without any complications like bleeding, hypotension, or organ involvement, without any evidence of the capillary leakage. So home management, outpatient management. So this mild dengue without any organ involvement, without much changes in your blood counts, so they can be managed in the home. Moderate dengue, so there the two groups are there: dengue fever with high risk or comorbid conditions, especially the infants, pediatric age group, geriatrics, diabetes, hypertension, pregnancy, coronary artery disease, with hemoglobinopathies like your sickle cell anemia, thrombocytopenias, immunocompromised patients, and platelet patients on the steroids, anticoagulants, and immunosuppressors. So these are the people are high risk individuals. So these definitely we have to give a much careful about these people, because they have to admit, and their hospitalization is a rule in this population. Dengue fever with the warning signs and the symptoms: you have the recurrent vomitings, abdominal pain, tenderness, extreme weakness, pleural effusion, ascites, hepatomegaly, splenomegaly, and elevated your PCV more than the 20%, and reduction in your platelet counts. So definitely they need the hospitalization. And severe dengue, the people with the shock, so definitely they need a tertiary level care. So these are how we have to divide the dengue fevers into mild, moderate, and the severe degrees. What is the workup? Laboratory diagnosis is very important. Virus isolation is easy nowadays. Antigen detection, serological diagnosis, and some supportive investigations. So the PT RT-PCR is a very much available everywhere. So you can advise them. This is a gold standard. And this is your antigen detections. NS1 antigen will be positive in the immediate stages for 1 week. And then there will be the IgM antibodies, and finally IgG antibodies. So interpretation of these tests is very important. NS1 detectable from the day 1, stay up to the day 18, but usually in the first week. IgM antibodies start on the day 5, that is in the critical period, and stays for about the 90 days. And IgG in the recovery phase, and stays for the years. So whenever you see a rapid dengue test, if the IgG is positive, that means he had the past infection of the dengue, nothing to worry at this juncture. So when the fellow is having the NS1 antigen positivity, he is in the acute dengue infections. When the fellow is having the IgM, he may be in the critical phase or in the recovery phase. And the patient is also having the IgM and IgG, that means this is a secondary infection, when the IgG has the higher titers. See, this is the primary infection. First, see the NS1 will be positive here, and then later the IgM will start, and finally IgG will start. When the fellow is also having the second infection, I told you the 5 serotypes. So if the person attacked with the one serotype this year, he will get the lifelong immunity for that particular serotype. So there may be chances of having the dengue fever and another 4 times in the near future, because there are the 5 serotypes so far, and 6 serotype is also detected. So one serotype, one time in the lifetime. But most dangerous is the serotype 2, serotype 2. So this is a secondary infection. So this already told you, both are the negative, IgM and IgG. Maybe not the dengue, or maybe the early sample. Maybe the fellow is in the most earliest febrile period, where the NS1 will be positive, whereas IgM and IgG will be the negative. So your clinical acumen to suspect here IgG, in spite of the IgM and IgG negativity, don't say that it is not dengue, maybe in the earliest phase. When the IgM is the negative and IgG is the positive in the low titer, that means the past dengue infection. That keeps the IgG positivity for years together. When the fellow is having the IgM negativity and IgG is high titer in the positivity, it could be a secondary dengue infection. So second strain has entered into the body. IgM is the positive, IgG is the negative. So the most primary dengue infection takes some more time to rise your IgG levels. At this juncture, IgM positive means the primary dengue infection. Both are the positivity, but IgG at the lower titer. So the most recent primary dengue infection. So that is the reason IgM is very positive, whereas IgG is the low titer. So start rising the IgG. So both are positive. IgG is at higher titer, that shows a secondary dengue infection. So high titer because of the primary past dengue infection. Now the IgM is positive because of the secondary dengue infection. So that is how we have to interpret these things. Other tests are also required, liver enzymes, your SGPT, HGOT, etc., creatinine and urea and your electrolytes, your AKA rule out, and cardiac enzymes, etc., to rule out any myocarditis. So this is a very common, you get the chest X-ray done and ultrasound abdomen and shows the pleural effusions, ascites, very common. Thrombocytopenia, leukopenia, these are very common. In patients with the dengue hemorrhagic fever, there will be increased hematocrit level, hypoproteinemia, a prolonged prothrombin time, prolonged activated partial thromboplastin time. So these are all features of your DIC. There will be the decreased fibrinogen levels. There will be increased amount of the fibrin split products. Here you have to introduce the fresh frozen plasma, etc. It's a rapid decline in the platelet count, or a platelet count less than the 1.5 lakhs. This is the thrombocytopenia, very common. So what are the reasons for the thrombocytopenia and the dengue fever? There are the three reasons. One is a decreased production. There will be increased peripheral destruction, and there will be increased consumption of the platelets. Decreased production because of the bone marrow suppression of your virus, affecting the hematopoietic progenitor cells. There will be the decrease of the defective megakaryocytes, less platelet production. Increased destruction, molecular mimicry, cross-reactivity of the dengue antigen with the platelets and endothelial cells, and destruction of the platelets and macrophages, phagocytes. Increased consumption because of the DIC. So by all these three means, we will have the thrombocytopenia. So this is the very important slide, shows you the atypical manifestations. CNS, there may be encephalitis, encephalopathy, seizures, and intracranial bleed, intracerebral bleed. So these are the very important causes of atypical manifestations as far as the brain is concerned. In the gastrointestinal, acute hepatitis, a fulminant hepatic failure, cholecystitis, cholangitis, and acute pancreatitis. They all require very intensive care. Renal, acute kidney injury, hemolytic uremic syndromes, and acute tubular necrosis. In cardiac, myocarditis is very common, and cardiac arrhythmias are also common, cardiomyopathies, and pericardial effusion as a part of your serogitis along with your pleural effusion and ascites. In the respiratory, you have the adult respiratory distress syndrome, ARDS, very common in dengue shock syndromes, pulmonary edema because of your rehydration, pulmonary hemorrhage, pleural effusions. In the eye, conjunctival bleed, a macular hemorrhage, visual impairment, and optic neuritis. So these are the important atypical manifestations of the dengue fever. In the DD, differential diagnosis, you have the dengue-like diseases like chikungunya fever, Zika virus. All the three are caused by your Aegypti. So Aedes aegypti will cause dengue, number one. Number two, chikungunya. Number three, Zika virus. Early stage of the malaria also looks like dengue, but nowadays we are not seeing the malaria, almost very much eradicated. Mild yellow fever, not much in our Indian subcontinent. Viral hepatitis is very common here. Leptospirosis, more common in Bengal and Orissa, and some parts of the Andhra also we are seeing. And viral respiratory and influenza-like diseases. So for you, the most important differential diagnosis is the viral infections. So treatment is mostly supportive, bed rest, paracetamol, aspirin is contraindicated for the fear of your bleedings, and fluid and electrolyte replacement, mostly the oral if the patient is not having nausea and vomiting. Otherwise, you can give the IV fluids. So mostly the treatment is supportive, bed rest and paracetamol, and oral or IV fluids. What are the indications for the hospitalization? So your warning signs or your shock syndromes, etc. So when the fellow is having the giddiness, collar extremities compared to the trunk and extremities, that is a peripheral shock. Oliguria with a dark urine, so most probably early AKI. Right hypochondric pain or the severe abdominal pain, maybe hepatitis or pancreatitis or cholangitis. bleeding from any side, persistent vomiting, and lethargy, irritability, restlessness, maybe because of the encephalopathy or encephalitis. Management priorities are replacement of the plasma losses with your colloids or crystalloids or with your uh, plasma. Recognition of the management of the hemorrhage. Prevention of the management of the fluid overload. This is also very important. Fluid overload should be managed very clearly. And prevention of the iatrogenic infections, which are very common in our dengue fevers. Colloids provide the volume expansion over and above the actual fluid volume infused. Your crystalloids had no added volume effect. So crystalloid means your RL and the NS. Colloids means your proteins, plasma, etc. Hence crystalloids, your NS and RL, are ideal for the initial resuscitation, and colloids better serve in the severe shock with undetectable blood pressure. So vote for NS or RL? Always vote for the NS. It is preferred for the RL because of the worsening of the tissue acidosis and the lactic accumulation, lactic acidosis. We give a lot of the NS when compared to the RL. But at the same time, if you give the larger volumes of the NS, that may also lead to the acidosis, hyperchloremic acidosis. So that may be the reason for your lactic acidosis from prolonged shock. And not only the sodium and the potassium, you see the chloride levels. If they are increased at the normal range, advisable change to the Ringer's lactate. Otherwise, you are giving a lot of the NS and increasing the chloride levels, that may go into the hyperchloremic acidosis. There you can change over to the RL. So ideally, start with the NS and then see the chloride levels. It is very easy to see when you send the electrolytes, they will give the sodium, potassium, and also chloride levels. When the chloride levels are elevating, then that is the time to stop the NS and start using the RL. So RL should not be the initial agent of the choice in dengue fevers. So the mucosal bleed, see that profound thrombocytopenia, strict blood test. Don't give the IM injections for the fear of the hematoma. And the patient is having the black stools, tarry stools, etc., melena. So always there is an internal bleed. Management of the congestive phase, change over to the hypotonic fluids, decrease the infusion rate at a lower level, and diuretics and digitalis are important here with the cardiac overload due to the regurgitation of the fluids. This is, I think, the best slide of our today's talk. Do's and the don'ts. Don't use the steroids. They are not indicated and can increase the risk of the GI bleed, hyperglycemia, and immunosuppression. So don't use the steroids in the dengue fever. That is the first don't. Don't give the platelet transfusions also for a low platelet count. When the platelet count of 80,000, 90,000, or 50,000, 40,000, don't give the platelet transfusions because platelet transfusions do not decrease the risk of the severe bleed. Even though you give a lot of the platelets, they don't decrease the risk of the severe bleed and may instead lead to the fluid overload and prolonged hospitalization. Don't give half normal saline. And don't assume that IV fluids are necessary in all the patients. As long as the patient is not having the nausea and the vomiting, always oral fluids are better than the IV fluids. Again, do tell the outpatients when to return because you have to tell the warning signs. Dengue with warning signs, then he will come down because when the patient is having acute abdominal pain or reduction in your urine output, etc. Do recognize the critical period. I told you the febrile period, critical period, and the recovery phase. So the critical period, you should recognize the critical period and then act accordingly. Do closely monitor the fluid intake and the output. Respect the kidneys, respect the heart. So without respecting the kidneys and the heart, you keep on giving the IV fluids. So definitely the people will enter into the pulmonary edema. Do recognize and treat the early shock, whether the decompensated shock or the compensated shock. So decompensated shock, so definitely the patient should be admitted in the ICUs, and compensated shock you can treat with IV fluids. Do give packed RBCs or the whole blood for clinically significant bleeding. When the patient is having the clinically significant bleed, so definitely the packed cells volumes or the total whole blood or the plasma can be given. So the management, As of now, there is no approved vaccine or the antiviral drug for the definitive management of the dengue hemorrhagic fevers. The lack of effective therapeutic interventions for dengue has created interest in the alternative therapies like natural and herbal, etc. Here, the carica papaya leaf extract has gained a lot of interest in the treatment of the dengue. So, you're all familiar with this. They commonly called the papaya plant. It has long been possessed a number of the medicinal properties. How it helps? It contains the glucosides, papain, cristin, glycal endopeptidase, etc. So this is the carica papaya. ALOX12 and PTAFR that shows arachidinone 12 lipoxygenase and platelet activated factor receptor gene. So that's how they increase the platelet numbers. So they also upregulate the thrombopoietic cytokines, IL-6 and the stem cell factors. It also has an antiviral activity. What about the clinical trials in Indian patients? So they did some studies. It's a multicentric double-blind study. So raising the platelets from the day 3 onwards. So clinical trials from the Bangalore, from the Jaipur. So they are say that useful here. The sample size is about 200 to 300. Percentage increase the platelet count by day 3 and significant decrease in the hospitalization. In the pediatric subjects also proves better. The same thing happens here. Conclusion, shown to increase the mean platelet count in the thrombocytopenia associated with the dengue fever in the pediatric subjects, and the syrup was well tolerated. Even in the chemotherapy-induced thrombocytopenia, it's from the Tata Memorial Cancer Center, Mumbai. Nearly 700 subjects. They have given the caripryl 1100 mg TID. Convenient, cost-effective, safe, and efficacious adjuvant in the treatment of the thrombocytopenia because it increases the platelet count, marginal increase in the WBC, decreases the requirements for the hospitalizations, decrease the need for the platelet transfusions. What are the complications of the dengue left untreated? So dehydration, bleeding, hyperglycemia, hypoglycemia, erythmias, electrolyte, acid-base disturbances, severe co-infections. So these are all the signs of the recovery. You can discharge the patient, stable pulse, BP, breathing, normal temperature, no evidence of any bleed, return of the appetite, no vomitings, good urinary output esters. Prognosis, poor prognostic indicators, early and profound shock, delayed admission to the hospital, septic shock with gastrointestinal hemorrhage, and causes of the death. What are the causes of the death? The two negligence among the doctor's profession is failing to recognize that a patient is in the shock. So not touching the patient, not seeing the peripheries, not recording the pulse, not paying much attention on the respiratory rate, not recording the blood pressure properly. So you are missing a case of the shock. So there is a failure to recognize that. That is the most important cause of the death here. Again, failure to recognize that patient has entered the congestive phase. When the failure is in the congestive phase, keep on giving the IV fluids. So definitely again, a good cause for the death. So these two causes are very important reasons for the death in these things. Hypervolemia. So how to prevent the dengue? So the fight the dengue, best preventive measures, eliminate the mosquito breeding spots, remove all the sources, deny the Aedes mosquito of any chance to breed. So sanitation, good sanitation, vector control, and some vaccines. Remove the water from the flower pots on every alternate day. All the storage containers, turn over. Cover all the toilet bowls if going on the holiday. Wear shoes, socks, long pants, and long sleeved shirts. Vaccine is there. In conclusion, dengue is one of the world's most important emerging diseases. Rising the global incidence and explosive epidemics is a major challenge. And further understanding of immunopathogenesis and pathophysiology is required. and there will be the further identification of the better therapeutic agents. Right now, not much. Improved diagnostics, early detection to guide the evidence-based practice. To predict the epidemics early is very important. Develop an effective and the balanced functional vaccine for all the serotypes, and address the public about the disease as a global threat. So thank you one and all. All beware of that bite of the mosquitoes, especially female mosquito.